Well, let's go ahead and start. I know they're wrapping up the other meeting. So we're very pleased today to have Dr. Lihi Bar-Lev Schleider present, along with Clarissa Resendez, who works with her. Dr. Bar-Lev Schleider is a clinical researcher with over 18 years of experience in randomized placebo-controlled trials and real-world evidence studies in medical cannabis. She earned her PhD in epidemiology at Ben Gurion University at the Negev, and under the mentorship of Professor Raphael Mechoulam and Professor Victor Novak, obviously very giant figures in this field. She's led clinical research across multiple indications, including cancer, dementia, Crohn's disease, autism, fibromyalgia, and other complex chronic conditions. She established and directed Israel's largest real-world cannabis data registry, evaluating both short and long-term treatment outcomes and contributing to the scientific evidence that supported the expansion of medical cannabis indications in Israel. She currently serves as the medical director at Tikun Olam USA, where she contributes to the development of evidence-based medical cannabis programs. So Dr. Bar-Lev Schleider and Clarissa, we're really thrilled to have you join us, both in person and on Zoom. And please go ahead and start your presentation.
Thank you so much for having us.
Thank you.
We will just upload our presentation and we will start. I will start.
Okay.
So while Clarissa is uploading the presentation, I will thank you for introducing me. There's no much to add. Just part of our data collection, we treated in Tikun Olam Israel, we treated our patients in a specialized medical cannabis clinic, and we gathered all the information we could before the cannabis treatment and again after 1 month and after 6 months. So today I will present to you the clinical outcomes of medical cannabis treatment in elderly with polypharmacy. You already said that. So in the past 18 years, I was the medical director of Tikun Olam Israel. My PhD was in epidemiology on the subject of medical cannabis. I had the honor and the privilege that Professor Victor Novak and Professor Raphael Mechoulam were my supervisor and professors. And currently, as you mentioned, I'm the medical director of the Tikun Olam USA. So as you know, polypharmacy is a major challenge in geriatric care. It increases the risk for hospitalization, drug interaction, reduce adherence, reduce quality of life, increase the risk for adverse drug events, falls and fractures, cognitive and functional decline, and also increase the risk of mortality. In older adults, these risks are amplified because of age-related physiological conditions like slower drug clearance and increased sensitivity to drugs in general. Deprescribing, you probably all know, is extremely difficult. Even when clinicians understand that medication burden is harmful and they try to decrease the number of medication consumed by the patients, most of the deprescribing models focuses on one medication, on reducing one medication at a time. And usually it's not that easy because symptoms consist and then patients get prescribed with additional medication for the side effects of those of the previous medications, and they just trapped in that prescribing cascade. Most of the symptoms that typically experienced by older adults, like pain, like sleep disturbances, like anxiety and restlessness, like loss of appetite, nausea, spasticity, and other symptoms, are symptoms that may be improved with medical cannabis treatment. So the aim of this study was to understand what the outcomes of 6 months of medical cannabis treatment, mainly in changes in medication consumption, in pain intensity and symptoms intensity in general, and of course, quality of life and safety parameters of the treatment. So this is a prospective cohort study based on real-world evidence that were collected in Israel in a specialized medical cannabis clinic. In Israel, in order to receive a medical cannabis license, you have to have one of the indications that approved by the Israeli Ministry of Health, mainly cancer, pain, neurological conditions like Parkinson's disease, Tourette syndrome, autism, epilepsy, and dementia, and of course, inflammatory bowel disease, like Crohn's disease and ulcerative colitis. Apart from those indications, it will be very hard to receive a license. But when a patient receives a license, he can purchase the medical cannabis only under one of the approved medical cannabis suppliers. So if they receive the license under Tikun Olam, they can only buy in the pharmacy Tikun Olam's product. Today it's changed, but a couple of years ago it was like that, and those the results that I will present today. It allowed us a longitudinal tracking of each clinic visit, and of course medical cannabis treatment patterns. So before the cannabis treatment, all patients had an interview by a trained nurse for something like 1 hour, when we asked all the information I will describe shortly. The target population was elderly, patient 65 years of age or older, that using at least 5 different medications per day. The intake questionnaire included demographic characteristics, medical history, full medication list, including medication name, dose, and frequency for each medication, symptoms, pain level, quality of life, and function, indication for the treatment, and medical cannabis treatment recommendations. After 6 months, it was after 1 month and again after 6 months, but I will present results only of the 6 months follow-up, because the 1 month follow-up is mainly for us internally to adjust the treatment in order to decrease adverse events if the patient experience, or I can say when the patient experience adverse events, that's during the first month's evaluation. And the 6 months evaluation included changes in medication consumption, changes in symptoms intensity, of course, safety, we tracked side effects, and we defined treatment success as a reduction in medication consumption. It can be either reduction in the number of medication consumed or reduction in the dose. Patients with unchanged total medication intake or increased medication intake were classified as treatment failure. So statistical significance was considered as p-value less than 0.05. We conducted the standard evaluation according to the measurements, to what we tested. So during 3 years of recruitment, 3,123 patients that were 65 years or older received medical cannabis license under Tikun Olam's clinic. 1,765 of them met both of the inclusion criteria of the study, which were 65 years or older and at least 5 different medications per day. 455, which are 25% of the population, passed away during the first 6 months of the follow-up. Another 16% stopped the cannabis treatment, and 6% changed the cannabis supplier or did not start the treatment. The rest, 919, were in an ongoing active cannabis treatment, and only 724 of them answered our follow-up questionnaire, and they formed their final cohort. So at intake, there were very complex, medically complex population. The mean age was 75 years. You can see that nearly 1/3 of the median number of different medications per day was 8, but nearly 1/3 of the population consumed 10 or more different medications per day. The common indications for cannabis license were chronic pain, cancer-related symptoms, and Parkinson's disease. Here we can see the distribution of baseline number of medications. So 5 was the lowest number. We can see that most of the population consumed between 6 to 12 different medications per day at intake. And again, at intake, we saw that the patient on average reported 8.3 different symptoms for each patient. Those symptoms included, you can see 91% of the population reported suffering from pain, 80% from sleep disturbances, weakness, digestion problem, depression, and more. At intake, the most consumed medication class was opioid, and the most consumed medication, opioid medications included Percocet, Targin, Tramadex, and Butrans. So treatment characteristics, in general, it was a personalized approach. So each patient received the treatment to best fit the symptom that he suffers from. You can see that most of the patients consumed a tincture, oil applied under the tongue, and most of them received two different chemovars. So these are the results. In total, 349 patients reduced medication number or medication dose. It's 48% of the population, with confidence interval of 95% between 46 to 50%. So in the entire group, the reduction of the median number of medication was reduced from 8 to 7. But when looking only on those 48.2% of the participants that reduced their medication intake, the median number decreased from 8 to 6. Here, I wanted to show you that most of the patients didn't reduce the dose. Most of the success group, the two columns on the left, we can see that 42% reduced medication count and only 6% reduced the dose only. All the rest were classified as treatment failure, either didn't change their medication consumption or increase the dose. Only 6% increased the dose, even less. So you can see that the largest class to get reduced over time was opioid, and around 35.4% of the patients that consume opioid before the cannabis treatment reported stop consuming opioid altogether, and another 11.3% reduced the dose. Apart from opioids, we saw reduction in other analgesic, anti-epileptics, sedative hypnotics, and antidepressants. We asked the patients to evaluate the pain intensity at the 2 time points before the cannabis treatment and again after 6 months. On a pain scale that ranged from 0, no pain, it's a vast pain scale, 0, no pain, to 10, worst pain imaginable. And while before the cannabis treatment, 75% of the patients rated their pain intensity as 8, 9, or 10, severe pain, only 9% rated their pain as severe, 8, 9, or 10, during the cannabis treatment. The median pain level at baseline was 9, and it reduced to 4 after 6 months of cannabis treatment. So in total, 94.3% of participants reported improvement in their overall medical condition. 86.9% of participants reported improvement in pain. It's parallel. 84% reported reduction in sleep disturbances, restlessness, nausea, agitation, depression, anxiety, and lack of appetite were the most improved symptoms during the treatment. So we did exactly what we did with pain. We did the same with quality of life. We asked the exact same question at those 2 time points. You can see that while in baseline, only 8% of participants rated the quality of life as good or very good, 51% of the exact same group, the exactly same patient before and after, 51% reported good or very good quality of life at 6 months. In terms of safety, 32.4% of participants reported at least one side effect during the treatment. The most reported side effect was dizziness with almost 11% of participants. And apart from dizziness, we saw reports on dry mouth, sleepiness, psychoactive effect, nausea, increased appetite, and more. So while normal approaches for deprescribing focuses on one medication at a time, we saw that medical cannabis can affect simultaneously multiple symptoms, and those symptoms are typically experienced by older adults with polypharmacy. So while targeting so many symptoms simultaneously, we believe that might be contributing to reduction in medication, because we saw reduction in pain medication, reduction in sleeping pills, while improvement in sleep disturbances and improvement in pain intensity. So this is how our hypothesis. This study has some strength, like large prospective geriatric cohort, real-world clinical setting, high-risk population with polypharmacy, detailed medication level follow-up, multiple clinically meaningful outcomes, and 6 months structured reassessment. This study also has some important limitations. For example, it was an observational design without a control group, so we cannot report causality, rather just association And again, not all intake participants completed the follow-up, so it might be some survivor or responder bias to the results. We relied on self-report outcomes. We did the study in a specific Israeli clinic, so it might limit generalizability. The follow-up was limited to 6 months, and the patient used full spectrum and sometimes mixed chemovar, which limit the attribution to specific cannabinoid composition. So physicians are dealing with increasingly aging population that has multimorbidity and polypharmacy. So it's important to find solutions, or not even solutions, just to add one more or few more optional tools in the physician toolbox to use when trying to help patients both deal with the symptoms and maybe reduce some of their medications. So in general, to conclude, the study showed that the patients were adherent to the treatment. The treatment was both safe and effective in that very gentle population. And of course, further controlled research is required. These are the main reference for the study, and I want to thank you all for listening. Please feel free to ask questions, not only on that study, also on the studies that we have that slide. Okay. Also on other studies, on other indications. If you have any questions, please feel free to ask.